This presentation will be exploring tDCS and major depressive disorder, also referred to as MDD. The presentation begins with an overview of MDD before moving into an overview of tDCS and then the application of tDCS on MDD before finishing with gaps and future research. Starting with the physiological mechanisms of MDD. In regards to prefrontal cortical activity, MDD is usually accompanied by alterations of cortical activity and excitability, especially in prefrontal areas. It has been demonstrated that the activity of the prefrontal cortex is pathologically altered in major depression, and some studies suggest an imbalance between right and left dorsolateral prefrontal cortex, also known as DLPFC, activity as an important causal factor for major depression. Moving into neurotransmitter systems, MDD was earlier considered to be mainly due to abnormalities in neurotransmitters, especially serotonin, norepinephrine, and dopamine, as posited by the monoamine deficiency theory. This has been evidenced by the use of different receptor inhibitors as antidepressant treatments. Finally, GABA is the main inhibitory neurotransmitter and is essential for brain function by balancing excitatory transmission. It is vital for the regulation of mood, emotions, and stress, and those with MDD have lower GABA levels. GABA is considered to exert its antidepressant effect by inhibiting the ascending monoamine pathways, including mesocortical and mesolimbic systems. Moving into transcranial direct current stimulation. The physiological mechanisms of tDCS include cortical activity and GABA and glutamate. tDCS encompasses the induction of a relatively weak constant current flow through the cerebral cortex via scalp electrodes. Dependent on stimulation polarity, this results in a modulation of cortical excitability and spontaneous neural activity. tDCS has been supposed to normalize cortical activity by excitatory stimulation of the left DLPFC and the inhibitory stimulation of the right DLPFC. Further, the after effects of anodal tDCS are dependent on modulation of both GABAergic and glutamatergic synapses, which are modulated by acetylcholine and serotonin. The after effects of cathodal tDCS are dependent on the modulation of the glutamatergic synapses. The after effects of cathodal stimulation are modulated by dopamine, acetylcholine, and serotonin. Moving on to the application of tDCS on MDD, starting with prefrontal functions. So studies have concluded that tDCS of the left dorsolateral prefrontal cortex, also known as DLPFC, which is a critical area in the mood-related neural network, is able to influence working memory and emotional responses to visual material, which are both cognitive issues related to MDD. Because neuroimaging studies have shown the left DLPFC to be hypoactive and the right DLPFC to be hyperactive during depressive disorder, excitability of the left DLPFC or inhibition of the right DLPFC to treat depression have been studied, and both approaches show promise. However, the results about the clinical potential of these tDCS protocols to treat depression are mixed. In regards to reducing symptoms of MDD, a study by Boggio et al. Concluded that depressive symptoms were significantly reduced after 5 sessions of tDCS with 1 MA for 20 minutes once daily, as measured by the Hamilton Depression Score and the Beck Depression Inventory. The mean reduction in the depression scores were between 60 and 70% relative to baseline values. In a follow-up study, Boggio et al. Demonstrated that a single prefrontal tDCS session enhanced identification accuracy of emotionally positive visual material, providing evidence that prefrontal tDCS might improve depression by an alteration of emotion-connected information processing. Finally, in regards to GABA and glutamate, the extent to which tDCS modulates behavior is not associated with a single neurotransmitter, but instead relates to the fine-tuned balance of excitation and inhibition. Both anodal and cathodal tDCS significantly change the ratio of inhibitory GABA to excitatory glutamate with individual temporal specificity. Because decreased levels of GABA and glutamate have been found in individuals diagnosed with MDD, the balancing of these neurotransmitters through the use of tDCS proposes that it is an effective mechanism to utilize the disorder's treatment. Finishing with gaps in future research. Moving into future research. Future research should include the exploration of the use of tDCS and pharmacology-based interventions concurrently, and the use of tDCS and behavioural therapies concurrently, as there is evidence showing that tDCS has its largest effects when associated with other interventions, such as antidepressant drugs and cognitive behaviour therapy. Further, replication of previous studies to verify results should include larger studies and studies in different populations, which are needed to confirm the results of these initial findings. And finally, there is a possibility of tDCS as an at-home treatment, as tDCS devices are affordable, accessible, and can be purchased by untrained individuals, including MDD patients. However, this could be associated with ethical issues, as patients are not trained medical staff and perhaps should not be allowed to administer electrical stimulation treatments themselves. To conclude, research has demonstrated the effectiveness of tDCS to treat some physiological aspects of MDD. However, it is far from being an optimal and entirely effective treatment option. Further research must explore the optimal current and positioning of tDCS that can be used to best treat the disorder, and should focus specifically on MDD, rather than applying findings to the disorder when they are relevant.